As you are probably aware, there are a lot of oncogenic drivers identified in pathogenesis of non-small cell lung cancer, and a lot of those are actually targetable with novel drugs that are currently in development. And what I wanted to highlight at the ELCC symposium was a novel driver called cMET. cMET, it comes in two ways. One is a mutation that is called a cMET exon 14 skipping mutation, and one is in the form of amplification of the cMET gene. And both of these are actually targetable with drugs, with tyrosine kinase inhibitors, of which one of is already available. The drug is called crizotinib. You may know crizotinib was developed as a cMET inhibitor, but was found to be very active against another target called ALK. But we know there are some data already available about the activity of crizotinib in that situation. And there are several other cMET specific inhibitors in development, such as drugs such as capmatinib or tepotinib, which are currently undergoing phase 2 testing. There are also some data in the public domain suggesting that chemotherapy is not that active against patients, tumors of patients with these molecular alterations, and neither is another class of drugs that we use in treatment of non-small cell lung cancer, PD-1 or PD-L1 inhibitor. Those are very preliminary data, but all that they suggest is that these are not very active against metastatic non-small cell lung cancer, at least not that active as those novel agents that I just told you about. The standard of care treatment now, which is chemotherapy plus or minus immunotherapy, typically is associated with a response rate of approximately 25 to 30%, with median progression-free survival times of approximately 6 or 7 months. And you may know that chemotherapy is associated, or can be associated with, quite some side effects, as is immunotherapy. These drugs, these novel drugs, are typically associated in the situation where patients did not have had any prior treatment. Response rates that are exceeding 60%, major response rates exceeding 60%. They have a much longer response duration, i.e. progression-free survival time. And in addition to that, these drugs are active in the brain. You may know that is a good advantage of it, because brain metastases frequently occur treatment course patients with advanced non-small cell lung cancer. So that is an advantage, contrary to chemotherapy, which typically does not have any activity in the brain. And these drugs are associated with much less severe side effects. What limits in the clinical situation the use of these drugs typically is edema. So normally these drugs are administered on a daily basis, either once daily or twice daily. But in the long run, people frequently develop edema. So if you do not want to have patients buying new shoes, you have to interrupt treatment on a frequent basis. And I think that is a problem that we need to solve in the further clinical development of these. Well, like any other tyrosine kinase inhibitor, class of inhibitors, the clinical efficacy of these drugs is limited by treatment resistance. There's not much known as of this point in time why these how this resistance occurs. There's one small series from Memorial Sloan Kettering that was presented last year at ASCO that suggests that if these there are secondary mutations in the cMET gene in the case of cMET exon 14 skipping mutations, or that the tumors lose their protein, lose the expression of the protein, which is also associated with treatment resistance. Now, these secondary mutations may be overcome with different tyrosine kinase inhibitors, and there are some examples of that already. But how we have to overcome this resistance mediated by losing the protein is much less clear at this point in time. I think we will learn that there are much more of these targetable oncogenes if our capacity to interrogate tumors at the genomic level increases.